Professor Salman Sharif, who will be presenting the first case. Salman, you happy to go?
Yeah, Emma, do you have the case? Can you show the case, please?
Yes, sir.
Okay. Sorry, we were in a mock examination and we just finished a little while ago. So I just came back. I just broke the fast, so I need Emma to help me here.
Sir, can you see the case?
Right. I can. Can you all hear me?
Yes.
Yep.
Good. All right. So this is, sorry, go back. Just go back there. I'm just going to introduce the presenter. So Dennis, I believe, from Federal Center of Traumatology and Orthopedics in Smolensk, Russia, and he's going to be talking. This thing is okay. Smolensk. Fracture dislocation is a case that we are presenting. So 61-year-old fall from 1 feet height, I think 25 days ago. Yeah. And he had cervical pain, VAS of 7, less range of movements in neck due to Beach-2 disease, disability caused by pain, and no neurological deterioration. This was the radiology. Anybody wants to take the radiology? Do you have any volunteers who want to talk about the radiology? No volunteers. So I think, Sandeep, am I going to go through the whole thing, or is there you guys are going to give expert opinion on this?
I think Salman, you present the case, and then we all give expert opinion on that. But you will be the first expert to present it and to provide your opinion.
Okay. So this is clearly a problem with the fusion, diffuse fusion overall, and obviously, ankylosing spondylitis is kind of thing that you could have. You can have various other sub forms of those, but if you have a trivial trauma, then you could end up with a scenario like this, and in which it seems to be a fracture dislocation. And I don't know, I can't see the posterior aspect, what's happened there, but anteriorly you can clearly see there is dislocation there. There's a fracture going through and spondy coming along with that. So obviously we need an MRI for this. Oops, don't have an MRI. So the question here for the board is there surgical treatment or not? Are we going to do an anterior approach, plate or antibody grafts, or posterior approach, and pros and cons with screws? So Sandeep, do you want to take this case?
Yeah, sure. So yeah, I think because these are very difficult to, spontaneous fusion would be very challenging in these, and he's got significant pain. So I think surgery is warranted here. And though generally in such kind of dislocation, one can do either anterior or posterior approach. But in this particular situation, I would prefer a posterior approach. You can see the surgery would be fairly straightforward, and if you see there is significant kyphosis, sometimes you can find getting space pretty challenging. So because the neck would be completely bent, so I would prefer a posterior approach.
Okay, Vasilis, your opinion on this?
Yes, I think I agree with the surgical approach. This is an unstable injury, in my opinion, even if the mechanism is not significant. I would suspect that there might be some fracture of the facets or some dislocation. And because of the AS diagnosis, I think we have two large moving segments. I think a posterior approach will be needed, in my opinion, but sometimes I'm favoring in these cases an anterior and posterior approach, meaning I would do an ACDF from the anterior part, and then do a posterior instrumentation. It has to do with the characteristics of the patient. Sometimes the anatomy make the anterior approach very difficult, and I agree. But sometimes it is very important to see if the facets are locked, if there's a capability to reduce the patient intraoperatively, or if we need a combined posterior-anterior procedure sometimes, if this is not possible. I don't know if you have any strong thoughts about doing traction preoperatively. I was in favor in the earlier years. I don't find it as helpful now. Most of the time, I would be able to achieve good intraoperative alignment with positioning and gentle traction in the OR. Having put all these things together, I would favor also a posterior approach plus minus an anterior decompression infusion at the level of the subluxation.
Okay, is it possible to unmute Stacy? She wants to say something. Imad, can you please unmute Stacy Darwish, please?
Hey. I'm unmuted now. So yeah, I would agree. So uniphyseal dislocation in a stiff spine, assuming shape was acceptable, I would do awake traction to get it beautifully reduced, which is what we would do in our unit. He looks like quite a large neck, so much more pleasant to go in the front than going in the back for screws. That looks quite a sizable neck. I say, so if I could get it reduced, I would do anterior with a collar for 12 weeks, and then based on the MRI scan as well, obviously. If I couldn't get that or the shape of the neck didn't facilitate, I would do posterior to reduce and pedicle screws, but that's just my preference.
Stacy, why MRI?
MRI for me to decide on need for decompression. If there's a hematoma in there, I'm decompressing it. If there's no hematoma in there, I ain't decompressing it. If there's no neurological deficit, he presented 25 days down the line. So, I mean, they're commonly missed fractures. They often are sent home by ED. Yeah. Uniphyseal dislocation is one of the most common missed. But also, I want to know what state the posterior elements are in, given how stiff his spine is. And that would also give me a lower threshold for doing a front back. I'd have a very low threshold for doing a 360 fusion in this guy. But I say if the back is just at that same level, you could do a single level ACDF and 4 screws at the back and it would look beautiful.
Excellent. Nikolai, your comments?
We had, I think it was not long ago in Northern Ireland, a case when the patient was neurologically intact, and then it was decided that similar situation, the patient was subjected to MRI scan, and because of the moving back and forth to the MRI scan, the patient developed neurological symptoms. So in that particular case, I would not necessarily ask for MRI scan. I have enough diagnostics here on the CT scan, and I probably will favor Vasilis's decision of posterior and anterior angstpont, relatively young person, so I would probably do anterior posterior.
And why just, if you're happy with the posterior approach, would you still do anterior?
Well, I probably will just consider doing anterior posterior as well. Yeah. So I'll sleep better like that.
Okay. And Stacy's opinion regarding MRI, where would you not do it? Where would you do it? Sorry, unmute yourself.
So I would always MRI these because I want to know what the hematoma is like. I would ideally get an MRI scan on the morning of surgery. And I disagree with Mr. Pev there in the fact that if you develop neurological compromise by being slid onto an MRI table, then you are going to be neurologically compromised with proning to do a posterior approach. So therefore, if that's going to happen, it's going to happen no matter what. So therefore, your only way of predicting against that is to do neuromonitoring the whole way through all of these things, which we're never going to do for MRI. But I think if you're going to develop that degree of compromise with a log roll onto an MRI table, you were screwed anyway.
The only thing is that on the MRI scan table, it would be whoever positioning the patient in the operating theater. It will be me or somebody who is aware and surgeon.
MRI require a spinal person to be there if it's a log roll person. It has to be somebody from orthopedics or somebody from neuro that has to be there. I worked in the same hospital as you. So it has to be somebody from orthopedics or from neuro. If it's a scan for an unstable neck, it has to be positioned by one of the surgeons.
Has to be, but not always.
No, it is. They won't do it otherwise.
Okay, if there is a
I think we agree to
there,
disagree.
then I agree.
Yeah, I would get an MRI scan just to decide on decompression and length of fixation at the back. Also looking for other fractures.
I would agree with you. There is a there. Yeah, I'm with you. If there is a spinal person that is on the MRI scan.
Yeah.
Okay. So let's see. Shall we get people to vote? What percentage would go anterior? What would go posterior? How about people? If you have this reaction, so go into the reaction and just give thumbs up if you're going to go only posterior. Ahmad, can you calculate? Is there any way?
But I'm not getting any reactions.
Okay, so we can't. Maybe next time we should have something like that to help us. Anyway, so can we go on to what they did? No, sorry, you're supposed to go next. Maybe we have something there at the end.
Yeah, there is a surgical solution in that presentation. Yeah, it's actually interesting. It might be good to comment on that as well.
Okay, brilliant. We'll start with Stacy, actually.
Ooh, that's interesting.
Can we enlarge it a bit, please? Ahmad, can you?
Hooks. The presenter used hooks to fix posteriorly.
Okay, so being super critical because we're an orthopedic or a meeting, it's not reduced, and it's been fixed with hooks. So I would say that is probably not sufficient fixation for me to leave them either free from a collar. So you've now still got all the morbidities of a collar. There's no absolute stability here with that, given the fact it's sublaminar. Now, obviously, we didn't see the scan in full detail, but I say it's not reduced. So I would have said a front back, but that's a personal thing when I do these fixes, which I do fairly regularly.
Nicolai?
I agree with Stacy. It is not reduced. It is not stable. The hooks are not providing rotational stability, and I think that patient is still in danger.
Sandeep?
Yeah, I totally agree. But I would have done C4 to C7. Pedicle screws if possible. Otherwise, C4, 5, 6 lateral mass and C7 pedicle screws. I would still have done posterior only because in this situation, anterior, we get quite a few ankylosing spondylitis cases, and I know anterior could be sometimes even just to dissect out the space can be very challenging. I would have, if I can get away only by doing posterior, I would still do only posterior. And in this case, though the MRI pictures are not there, but if it doesn't show any significant compression, I would just do a posterior approach.
Vasudev?
Yes, I'm a little bit skeptical because of the long arm of the forces. So I would definitely do a long construct on this patient. I would look a little bit more of the films, but it's not unusual for me for these cases to be a C2 to T2. I know it's kind of, but I don't want to run any risk of instability, especially if I'm not doing an anterior approach. That's my preference.
Yeah, I would have gone a couple of levels above and below and just do it posteriorly. But yeah, I think it needs to be reduced. But if when you're in certain circumstances where you don't have proper gear available, or maybe some images are not as good and image intensifier is not as good, then maybe that could have been an option maybe a couple of decades ago in some of the places, but not now. Would you agree, Nikolay?
Yes, so I can see that we are all agreeing that long construct posteriorly, just because there is too long levers with this ankylosing spondylitis, and we have to fix it appropriately. If we have to go only posterior, I agree, then we have to be longer. If we go front back, then you can probably allow yourself to be shorter at the back, and then rely also on the anterior fixation.
Okay, brilliant. Is there anybody for any more comments? Can we get the person who put this in, get his comments that why did they do posterior and that particular construct? Imad, can you unmute the gentleman if he's there?
Let me check, sir.
Anybody from the audience has any comments in the meantime? If you have, you can write on the chat.
Sir, he's not
just...
there, sir.
Okay, no problem. So I think we're going to wrap up. We'll go on to the next case. Nikolay, all yours.
I think the next case has to be presented by Sandeep. I think that's what
I'll share my screen. Can you see my screen?
Yeah.
Okay. So this case is presented by Muhammad Diki Dayatullah from Indonesia, Bandung, Indonesia. So this is a 50-year-old guy with weakness of lower extremities. And the recent medical history was he has weakness in both lower limbs for last 2 months, bladder bowel involvement for 3 weeks. And for last 2 weeks, patient cannot walk with back pain relating to both lower extremities. And there is numbness. So his bladder bowel is involved and he has got motor and sensory involvement. And in the previous medical history, he had progressive weight loss of more than 5 kg in last 1 month. And 1 year prior to admission, he had a lump on the back, which was getting bigger over time. And the biopsy showed that it was a myxofibrosarcoma. He was on chemotherapy. I think 4 cycles were given. There's no mention what chemotherapy was given. And he was given full radiation, but the exact dose is not mentioned here. And then he has diabetes mellitus for the last 2 years. So the neurological examination shows that he has got numbness below T4 and reflexes. There is no sacral sparing. Babinski's muted. There is clonus. I don't know what is vegetative state, which is within normal limit. There's no atrophy, and upper limbs were normal, and hip below the power was 0. And so MRI is suggestive of a large mass here. So anybody would like to comment on this? I'll show you more images. So here you cannot count, but this is, I think, T4, which you can see in later images. And I think 1, 2, 3, 4, 5, 6, 7, 8, 2, 3. This is T5. So there's a large mass here with significant cord compression, involvement of the T5 vertebral body, and I think there is some involvement of the ribs also here, and there's this huge mass which is compressing the spinal cord. And this is T2 image. And so these are other images. Now the question for the board is, what is the best treatment for this patient? Whether you would do a safe resection or a total removal, and what are the other management options? Salman, would you like to go first? Pardon?
The patient had already, I'm not sure if I missed that. The patient had already 4 courses of chemotherapy and also radiotherapy.
Radiation. Yeah.
And the patient had biopsy. This is also
yes. That was all in previous history. And in last 1 month, he has progressively worsened, and now he's paraplegic for 15 days.
Yes.
I think you need to go to tumor board and discuss this with your oncologist and see what is the best way forward for this particular kind of tumor and decide accordingly. Obviously, if they say that you need to go in and do something about it, and if they can shrink it, and what's the outcome like? So there are many factors that will come into play. If the outcome is reasonable, which it doesn't seem like, then obviously there are possibilities of surgery and taking it out. And if it's unstable, then you fix it at the same time. On the other hand, they might give chemo first and then
they have already given chemo and radiation. So he has progressively worsened.
What's the outcome like?
So he has history of paraplegia for last 2 weeks. So
I think the chances of him recovering are negligible. And I think, if you're going to be heroic, you could be heroic, but are you going to cure this patient? Probably not.
Would you do a PET scan first to see the extent of the disease?
I would get
other places.
I would get the oncologist to do all the workup and tell me that, this patient would benefit from my surgery at this stage, which is 2 weeks with paraplegia.
So I can see that Stacy commented no surgery. I think the moment had been missed. At least in my books, the strategy to this tumor would be surgery, aggressive surgery, but in the beginning, in order to remove as much as possible tumor tissue. And then the tumor to be treated with chemo and radiotherapy. And I was reading about these tumors. The 5-year survival is 60-70% with appropriate treatment. Unfortunately, they just did a biopsy in the beginning, and then they decided to do only chemo and radiotherapy. And at that stage, when the tumor is already quite advanced, and there would be a point of quite aggressive surgery if we have to do something, and with the view of the tumor probably will not be cured and the patient will not recover neurologically, I would say probably I would agree with Stacy, and no surgery. It's going to be a palliative treatment at that stage.
Vasilis, what is your opinion about this?
Well, I think that we'll try to establish the goal for the treatment now. I agree with you to have an idea about the prognosis from oncological standpoint. In terms of neurology, I agree also that the chances of improvement are quite low, even with the best of decompressions 2 weeks after being paralyzed. What I would do a CAT scan also to make sure that there's no instability or pending instability, and that would be a reason to operate. Given the fact that the prognosis is not good and the recurrence rate, I think, is quite high with these tumors, doing any kind of heroic surgery may be quite challenging. That's what I would say.
So all of us agree that after 2 weeks of paraplegia and a malignant disease, and extensive malignant disease, the chances of improvement are extremely low. So there is no point in doing a heroic surgery, right? Now the question is, he has already been given radiotherapy. he wasn't chemotherapy when he worsened. So what are the options left for us? We can easily say that we can go to the tumor board, but what are they going to decide? Like they have already tried chemo and radiation. So are we just going to leave him, or still we offer any kind of surgery, knowing that that is just to save life, but knowing that he's not going to improve, would we still do any major surgery here?
No.
I think it's important to have the opinion of the patient and the family. What are the expectations? What would be acceptable in terms of his quality of life? We do not know if the patient is. I'm sorry, I didn't see all these details. If he's in severe pain, all of these things will play a role in the decision. Yes, I think it's preferable to avoid quite risky surgery with a very unfavorable outcome. But sometimes if the patient has a chance to be sitting up for the rest of the life instead of laying down on the bed, that might be a consideration in my practice.
Now, suppose if this patient had come to us 1 month ago, when he was still able to walk, he had weakness, but he was still able to walk with support, or his bladder and bowel was not involved that much. What would you in that case? What kind of surgery would you do?
Well, I can give my opinion, but I would be interested to see what I would try to see a little bit more about the anatomy. I think a quite extensive resection of the dorsal element of the tumor would be my goal. Most likely, I will instrument the patient, and I would consider plastics for closure of the wound. This will be my first thoughts.
Salman, what would you do then?
We'll get Stacy to say something. She's writing something on the
Okay.
chat.
Salman, if you get patient in Pakistan, will you send it to Stacy in Ireland?
Absolutely.
Possible.
Send them all over.
Yeah. Yeah, sure. Why not?
So for me, this is obviously a complex case. If you're getting them pre-radiotherapy and pre-neurological compromise, you can go as aggressive as you like. If this is their only lesion and you're aiming for sort of potentially either curative or good prognosis. The difficulty you have is if they've had neoadjuvant radiotherapy, which often these sarcomas do, and I work in the sarcoma center. The sarcomas often get neoadjuvant radiotherapy. So if they've had radiotherapy to this, the worst thing for this patient is to live the last however many months of their life paralyzed and with metalwork sticking out of their back as their wound has fallen apart. So I agree entirely that if it's pre-radiotherapy, you can go as aggressive as you like with being neurologically intact. At this stage, unfortunately, post-radiotherapy, assuming it's to this lesion, and paralyzed for 2 weeks, there's absolutely no benefit to this patient, even for seating, in terms of doing surgical intervention here. All I'm going to do is cause a world of pain for this patient with radiotherapy, post-radiotherapy tissue.
So right now, so we all agree that right now we will just do pain management for this patient, right?
Pain management and whatever other options they have in terms of further chemo.
Therapy, okay.
But it will be in the plane of palliation. No, it's not obviously it's not going to agree anything more than that.
I think you all agree that we have missed the bus here, and there's something could have been done before, but now it's too late.
Yeah.
Okay. I think we can go to the next case then.
Yeah, so the next case is also interesting case of I think it's unfortunately I was going through the cases. The images are not very, very detailed, but still I think I can see it's a case of cervical spondylotic myelopathy of a relatively young man. Vasilis, are you happy to continue?
Yeah, I'll be happy to. Should I share my screen, or would it be possible to pull up
I think either ways, if you want to share screen or if you want EMAP to share the screen for you, either ways, whatever works for you best.
Okay, I'll try to share my screen. Okay. Can you see that?
Yes.
Okay. All right. So this is a case from Dr. Ahmad. This is the patient that comes with significant weakness. He's a 45 years old gentleman. He has not been able to walk for approximately 20 days. He has left hemiparesis with some weakness on the right side and intact bladder and bowel control. In his exam, he is bedridden. He has 3 out of 5 on the left upper extremity with 0, with unable to make any hand grip. The right upper extremity is 4 out of 5 with decreased sensation on the left side. He has positive long tract findings. And this is his image. Let's see if I can make it a little bit bigger. I think there's multi-level stenosis in the axial plane. This is a T2. So we can go to the next. I'll try to increase the size. Multi-level stenosis in the sagittal plane with, I think, increased signal on the spinal cord. So this is a gentleman that has long tract findings. He's got myelopathy with significant stenosis on the radiographic imaging. We don't have a plain film or a CT scan. I don't know if anybody would like to make any comments about the imaging or anything so far.
Yeah, I think the problem here is that obviously you need better quality MR to see really there's a myelomalacia there. Second is that you need a CT through this to see is there an OPRL. That's what it seemed like on the axial images. And obviously then, many other factors and the history regarding the, has it got sphincter involvement at this stage or not, we don't know that. And then depending on, obviously, then you decide how you're going to treat this patient. So there are many ways of going about it. And, for example, if you say it's a 3-level issue, then I really don't know. Can you enlarge that further, please?
I think this seems to be the stenosis 2, 3, 4, mostly 4, 5, 5, 6, and 6, 7. These are the worst levels, in my opinion.
So if it's a 2-level, then obviously you can approach this anteriorly. But if it's more than 3-level, then you can or 3-level or more, then you can think about posterior approach. But CT would be very helpful to decide what kind of procedure exactly you're going to do.
Yes, I agree. I think it's always we're always worried about OPLL, and in my opinion, there's no optimal surgery for everyone. Everyone is a little bit different. So let's see the questions. I think the first, I'm sorry, 2 questions are pretty similar. What's the best treatment, and what would be the best procedure for this patient? I think that overall, in cervical spondylotic myelopathy of moderate or severe degree, that most likely this patient falls into this category. I would say surgical treatment is the best option, in my opinion. The goal will be to decompress the spinal cord and perhaps stabilize the spine, depending on what is the degree of instability or the characteristics of the patient. I don't think that the patient has any problems with his sagittal balance or loss of cervical lordosis. I think that if there's no obvious OPLL, given the patient's young age, I would favor a 3-level anterior cervical decompression effusion for something like this. If there was suspicion for OPLL, I would do a posterior approach. Again, there are different factors that play a role in the decision, the patient's preference, the possibility of recannularization and nerve injury, and patient's profession. All of these things can be important into my decision of what type of surgery would be. Generally, patients' expectations, patients' demands, and surgeons' experience and preference are the major drives for this decision in my mind. I don't know if somebody else will do something different on this patient or has any preference or any other opinions. I would be interested to hear the opinion of the panel for a disc arthroplasty in myelopathy. I'm open to any further comments.
Stacy, you want to answer your question?
So that was my question again, not in this case, because obviously if he's 3-level disease, you wouldn't be doing a disc replacement, or you couldn't do a disc replacement because it's not licensed for that. My question to the panel was, who would actually consider doing a disc replacement in a young patient with an acute disc prolapse for acute myelopathy? Like this guy is 3 days, 3 weeks worth of features.
Yeah.
Who would
I wouldn't do that for these two reasons. Yes, first of all, there's no FDA approval for more than 2 levels, and my feeling is that in cervical myelopathy, there's a suspicion of a dynamic component, and if we do not eliminate that, the chance of improvement may be compromised. So I've never done arthroplasty for these patients, and unless something changes, it's going to be hard for me to do that. But there is still some papers out that have described this, and who knows, maybe something we'll see in the future. That's why I'm asking.
So in this case, I agree with you entirely. I would either do a 3-level ACDF or a 3-level posterior, depending on what the CT scan showed in terms of OPLL. I fully agree with that. I have done disc replacements for acute myelopathy in single-level disease in somebody with a pristine rest of their spine, with an acute cervical disc herniation, no posterior stenosis, and just somebody who slipped a big disc, who's pranged their cord, who's grossly myelopathic. I have done it. I just wondered.
But did the patient that you did had significant cord changes also?
Yes.
Mm-hmm.
So I say, obviously with myelopathy, our indications for surgery are always to prevent further deterioration. It's never for cure. We always know that.
Yeah, I agree with you.
Prognosis is going to be variable. We're stopping deterioration. We're aiming for improvement. I know there are some people who are only doing fusions and not even bothering to decompress now. Some people that was presented, I think, at Eurospine last year. People were just talking about doing a cervical fusion, no decompression for myelopathy, which doesn't sit that well with me. I think if I'm going in there, if you're going through an operation, you're getting a decompression as well as something else done. Now I say the question is diffuse or not diffuse.
So it's brave variation on fusion technique.
I've done it a few, as in the very young patients with the single-level disc.
Yeah, so I have done a few disc replacements in chronic myelopathy or single level, but and when we showed that there was no other instability or anything, but in acute myelopathy, I don't think I've done any.
Yeah, I think that also I should have clarified a little bit more. Says you're right. If the etiology for the myelopathy is a large disc herniation, that's reasonable to do an arthroplasty. But if it's spondylosis with severe osteophytes and almost angular spine, I don't think that you gain a lot by doing an arthroplasty. That was in my mind when I was asking about the disc replacement.
Oh yeah, in this case, definitely not.
Yeah.
Even in the young patient.
How many people would do a corpectomy? Like you were talking about 3-level ACDF versus posterior. Why won't you do a corpectomy if there is an OPLL?
If really this is an OPLL, you could do corpectomy. It's fine. It's a young patient,
Because
so
if you
you could
see
do
the
that.
axial cuts of the MRI, there is an element of OPLL. If you see the can you show the axial cuts of the MRI?
Yeah, that's
I
what
think
it seems like, but it seems like may not be the answer to this. So we do need better
So
imaging.
we will need, of course, we will need a CT scan for that, but I'm just asking a theoretical question. If there is an OPLL, it's a 3-level disease, so I think doing a 2-level corpectomy should be 2-level corpectomy versus a posterior. I think both are good options, and depending on
You
the
can
surgery.
consider hybrid options as well. You can consider one level corpectomy, and then the other level,
Other level
if it's not
discectomy,
so bad,
of
you
course.
can do just discectomy.
Yep. Totally agree with you.
I think that would be a good option.
I wouldn't, if it's OPLL, you get it done from the back from me because I don't like playing in the CSF. You guys like playing in the CSF. I don't like being in the CSF. So therefore I go in the back because he doesn't have any significant deformity. So he would be getting a posterior in my hands with OPLL.
I think I've noticed that I have better results when I do this anteriorly than from posteriorly. And, that's my general thing. And I've always much more comfortable anterior than posterior.
This is also what the research suggests.
And also, obviously, pain, risk of infection is much higher when you go from the back. And, those patients are miserable afterwards. And I think compared to that, anterior is much simple, straightforward daycare procedure.
I would agree with you, Salman. If it's in my hands, anything that I can do anteriorly, I'm gonna do it anteriorly. And my cutoff is not how many levels, but how fast I can do it. If I can do it within 3 hours, I would go anterior. If I have to fiddle so much, then I would consider posterior. But for me, the timing is most important because obviously the pathology that I'm addressing. But if I can address the pathology anteriorly, I would prefer anteriorly if I can do it fast enough.
Where is Nicolay gone? Nicolay, tell us about if this was somebody, this was a 75-year-old with other comorbids, would you still go anteriorly? Because the risk of causing dysphagia and also speech problems is much higher when you go beyond 75.
I would still consider anterior because there is other benefits of the anterior. Positioning is better for somebody who has comorbidities. Your anesthetist will love you more if you position him anteriorly. And if you are possible to, I never put my retractor, I change the position. And I don't have so much dysphagia, and I would consider doing somebody who is old with anterior approach, yes.
Well, Salman, I would differ. Like in a particularly significantly old patient, I would prefer to go posteriorly. What we have seen that whether you do it anteriorly or posteriorly, results are practically the same. Anterior has slight edge over posterior, but posterior also does pretty well. As you rightly mentioned that at that age, the risk of dysphagia would be significantly higher. So I would prefer to go posteriorly at that age.
Stacey?
I wouldn't use age as a cutoff for dysphagia.
Okay.
I've had young patients who've had significant dysphagia for a single level corpectomy, for trauma. I did a 90-year-old C23 ACDF last week with no dysphagia post-op for trauma. So therefore, I wouldn't use age as a cutoff for dysphagia.
So it's generally higher level disc that we have more problem than lower level. We know this.
Yep. She was 90 and I did a C23. So can't get much higher than that and much older than that.
But if you see overall, the consensus is that if you have got age in that age group, it's shown that you're going to have more complications than others.
But equally, as you said, quite rightly, going from the back is a big hit for the older population as well.
Agree.
Would anyone do only a posterior decompression in an elderly patient? would somebody do an MIS decompression? I've done a few, but I wonder if let's say it was a patient that is elderly, has very minimal movement in the flexion extension, very limited range of motion, almost ankylosed spine. Would you still instrument the patient? Would you consider ipsicontralateral decompression, MIS, or semi-open? What would be your thoughts about that?
I think if you could give the same results in neurology, then you could do an MIS if you are good at it. On the other hand, if somebody has got a poor JOA, you need to get that up. So that is your option. The whole idea is that neurology recovers, so or improves to whatever extent. So I think, my thing is obviously we try to do whatever is adequate. If you're happy with whatever procedure, do that. So it's fine if you're happy with anterior, posterior, or MIS, if you can give the same results.
Yeah, I don't know. Some of the most of the elderly patients that I did an MIS were quite happy, but I have not done it in a patient with severe myelopathy that will need an immediate decompression. I don't want to. I would prefer the classic, posterior cervical decompression infusion. But for some mild or moderate myelopathy cases, the patients are quite satisfied, and I see some improvement.
Anybody for any comments from the audience? Raise your hands. We can get you in if you want. Imad, do we have the person who sent the case? Or maybe somebody from Hayatabad in Peshawar?
I think we probably can organize the link
Sorry, Nikolai, can't hear you.
for the idea that we have to implement. Maybe we can involve even the idea to organize voting for probably for the next time. This time is already gone, unfortunately.
Okay. Professor Salazar is asking a question. What procedure would you do if the patient had advanced myelopathy? Sandeep?
Yeah, it doesn't matter whether it is advanced myelopathy or not, procedure will still remain the same. You have to ultimately decompress the spine. And again, it is an individual choice whether you do it posteriorly or anteriorly. I think most people will do whatever they are more comfortable with.
Anoop Thomas is
If we have a
asking.
few minutes, I wonder if we have a few minutes to address the last question about the prognosis. What is your experience regarding the prognosis? What would you expect, or how can we consult this patient about the prognosis? I think the prolonged neurological deficit is somewhat unfavorable for a good outcome, but the young age supports a better outcome on myelopathy patients. I will still do the operation, but what would you think would be the chances of improvement?
So
I think
obviously,
he has got a pretty good chance of improvement.
Yeah.
Can you go back to the first slide? I think his power was 3/5, right?
3 out of 5.
Yeah, I think these patients should improve.
Yeah, I think if the JOA in these age group is like more than 14, you have excellent results. And 11 and above, even in this age group, do very well. I think, and now and again, we see few patients, even a score of 6, 7, doing quite well. But, then prognosis also depends on the myelomalacia and contusion and how many levels there are, and how long the myelopathy has been. And what kind of support these people have. So many factors play a role, obviously.
I agree. I think that we all agree that we will do the surgery, and we will expect a reasonable chance of improvement for this patient.
Yep.
Nicola, you want to wrap up?
Yeah, I think we all agree for that case that we're gonna do surgery. The surgery will be obviously dealer's choice. Cervical spine is very forgiving, and basically you would do whatever you are more comfortable with, and most of the patients will do well with that. I think it's we had a great session today and great discussions, and I thank you all for your participation and for sharing time on your Sunday. So definitely good idea came from Salman to implement voting system. Hopefully we can organize that next time. Also, we agreed that Stacy is we will agree that Stacy is quite active, and we agreed on the last board that it's a good idea to invite external for the Spinal Cord Society people, although Stacy is not really external. But anyway, so Stacy will be part of my panel in one of my next meetings, and I think if you want to consider, I'm sure she will consider as well. And thank you again for all of your participation, and not only, and also I would like to thank the people which are also with us to discuss and to listen our discussions.
Thank you. You want to have a group photograph? Ahmad, can you please unshare this? Is this yours? Yeah, thank you. And everybody say cheese, and let's get a picture. Sandeep, it's okay to laugh. Good. Are we done?
I think we can say goodbye until the next time.
And happy Paddy's Day, Stacy. Bye-bye.